I was asked by a number of individuals to talk about the certificate of need and to give you an opinion regarding that. And what I thought I would do from Dr. Kavanagh's point of view and point of view of researching the subject, going through a number of items for you to consider, along with the history of certificate of need in the United States and in Kentucky, and along with some proposed regulatory changes that I think would be pretty beneficial. To start off on a few concepts, there's an iron triangle of healthcare. This isn't something I made up. This is throughout the literature. It consists of cost, quality, and access. And of course, you want to have low cost, high quality, and high access. And there's general wisdom is that you cannot have all three. You can't have all three of those arms being good. You can get 2 out of the 3 or 1 out of the 3, but you can't. It's very difficult to get high quality, good access, and low cost. And of course, there's transparency. And we define transparency as being value is equal to price plus quality. Those are the ones I sent, or the new ones? Okay, value being price plus quality. And there's something that we just toy around with, and that's value index, and that would be either list price or a charge to cost ratio or whatever, and looking also at adjusted nursing staffing levels. In other words, we think that with facilities, some measurement of nursing staffing, what's being provided, and of course that we have down adjusted because it makes a big difference whether you're a hospital in Lexington versus a hospital in Wayne County on what nursing levels should be and what list prices are. And we do believe as an organization that list prices do matter. I know that that's kind of a subject of debate, but I think in all other areas, especially when you buy a used car, list prices vary. History of a certificate of need in the United States. Number one is it is designed to save costs by preventing duplication of services. That's the whole theory behind the certificate of need. It was first enacted in 1964 by New York. It's the first state to enact the certificate of need law. In 1976, the Federal Health Planning Resource Development Act mandated that states have a CON by tying this to Medicare and Medicaid reimbursements. At that time, government was paying with a cost plus type of reimbursement. They were not doing DRGs, which is payment per diagnosis. By 1975, 20 states had CON laws. By 1978, 36 states had enacted CON laws. And at the peak, the easiest way of explaining it is everybody had a CON law. Now it's kind of hard to explain because, what's a CON? There's kind of a gradation between licensure and CON. Oftentimes it's said that Louisiana did not have a CON law. They have another system that is so similar there's practically no difference, so I'm going to include Louisiana in that. By 1987, though, the federal government said, this isn't saving money. Mandating or trying to control the amount of duplication isn't for saving money in a cost-plus system, so they withdrew it. And it was felt to be, at least in part, due to that by one of the major CON researchers, Morrissey, and he published a expose, a very large book chapter in the year 2000. You should also have a reference sheet, by the way, in your handout. So in other words, the CON was promoted by the federal government, and really by regulation was kind of stifled free enterprise. You couldn't have free competition. We didn't want to duplicate services. It didn't work, and they abandoned it. And then the states were kind of left in a predicament of what to do. Now, currently, 36 states have some sort of CON. And when they say 36 states, that also includes Ohio, which has a CON on long-term care facilities, Nebraska on long-term care facilities and rehab centers, and I'm also putting in there Louisiana, which retains control over assisted living facilities and long-term care and intermediate care facilities. Now, according to the National Conference of State Legislators, states that have retained CON programs currently tend to concentrate activities on outpatient facilities and long-term care centers. Let's talk about history in Kentucky. We enacted this in 1972, 2 years before the federal mandate. Healthcare costs are controlled by limiting competition with certificate of need. The theory is a costly duplication of healthcare is prevented and the consumer benefits. Now, the Kentucky statute, if you read this, and I kind of got, when I read this, I said, gee, they're asking for the impossible, that the certificate of need is to improve quality, increase access, and create a cost-efficient healthcare delivery system. All three of those iron sides of the iron triangle have to improve with Kentucky CON under CON law. And again, general wisdom is that's not possible or extremely hard to do. Kentucky looked at the CON back in June of 1997, and these are some LRC staff notes which were obtained during the meeting. We have very good we have very good little researchers, and there are comments that are recorded here that CON does not control costs or increase access. They had Julie Denton Rose and John Gray were indicated being at the meeting. At the bottom concludes that Kentucky CON doesn't control costs or increase access. So they did not think CON not effective for two reasons regarding access. So it's not wasn't viewed too positively there. The official report, which came out in 1997, was that outpatient services and costs, particularly for outpatient services, that CON has fallen short on this, that managed care has really picked in and done a lot to contain cost containment, that CON services that is limited at best. Now, again, the report says that CON has done very little on quality, and that's throughout the literature. The CON has always been a tool to control cost. It really has not been a tool to control quality. And you need to realize that when you talk about CON, there's another group of laws, and that's licensure. Licensure can control quality. And in many states, the licensure takes on many functions of the CON. It can create requirements that require, all hospitals have, ERs, that all hospitals have to be a certain size, that can go on and on and on, that they can create all sorts of quality parameters, but those parameters have to be equally distributed to all applicants or all facilities. Historically, in Kentucky, the last revision of the CON occurred in November of 2005. And this started out, the original proposal was, when looking at costs, that costs would be analyzed by a negotiated rate. In other words, what's the rate people are paying? And that quality was loosely defined as a documented history of uncorrected quality control problems which threaten life, health, and safety of hospitalized patients. Examples include preventable rates of preventable hospitalizations, medication errors, hospital-acquired infections, etc. Now, the final reg changed negotiated rate to adjusted revenues, 150% above the state mean. And this was also for the hospital's planning area. And at 150% above state mean, that is a lot for adjusted revenue, because you have to realize Medicare, Medicaid pays the same for everybody. Quality, again, within the planning area, final termination of Medicare, final loss of licensure, final revocation of all licensed facilities within the state planning area. That means that every hospital in every county surrounding the county that the hospital's in would have to lose their license all at the same time before a CON would be granted. Pretty tight rule. Now the negotiated rate, changing the revenues, again, hospital has 75% Medicare, Medicaid. That means that there's only the 25% left of paying patients that would have to bump that. And so you'd have to have 3 times above the state average. And in this you also have that clause that, you know, every hospital in the surrounding state all at the same time would have to do it. So it really kind of shuts down, you know, the CON as far as hospital facilities go. And I do know, and I don't know what the status is, I do think that we're moving forward in some of the areas in Jessamine Bullitt, but we have some growing counties that really do need hospitals. And essentially, you could say we have a CON, but essentially we've got kind of the opposite of the CON. We have something that really doesn't function. And that, I think, was some of that was political as far as motivation. And that's just my opinion, but that's what it was with the previous administration. Now, how well does CON work in Kentucky today? If you look at, and this is data from 2003, 2004, charge-to-cost ratios, we're the 17th highest charge-to-cost ratio in the United States, and there's really no difference between, if you look at all the states with CON and all without CONs, and you compare them, there's not much difference in charge-to-cost ratios. Now, charge-to-cost ratios use the asking price or list price of charges. And what I understand, the KHA data, that's the list price, too, that they have.
It's billed charges.
Billed charges, yeah, what they have posted for the people. So, and that's, you know, again, I think useful data. The cost ratio, which the cost is the bottom denominator, there was general agreement at one of our meetings that cost is similar between hospitals. I also had a reviewer of one of the articles that I submitted that made a comment that 60% of costs are staff, and staff can be cut, so that not necessarily lowering your costs is a good thing. Sometimes that could be done through cutting of staff. Higher hospital charges lead to higher profits. It's not that profits aren't bad, it's just that charges do matter. And this was one study that was done which validates that. And now I had another, you sure we're on the same slides I gave you?
There's another one today. You want the other one?
Yeah, I want the other one, because I inserted a, just wait, yeah, that was the old one. I'm sorry, I should have did two. Yeah, I needed the one yeah. All right.
I'll just do from the beginning. You can.
Okay, I'll go up there. Yeah, because I inserted some other slides, and I just wanted to. There we go. All right. This is in Kentucky, okay? Because sometimes you know when you have arguments, you say, well, this is this, and this is this, and both arguments are valid. The problem is the magnitude of the argument. And that's what you've got to try to bring out. Well, if you look at charge-to-cost ratios, they vary in Kentucky between 1 to almost 7. So to say that charge-to-cost ratios don't matter would be similar to saying that if you go in to buy a car, like a used car, because no one pays the asking price for a used car, you know, I never would. It would be the difference of buying a car that's advertised at $10,000 versus one at $60,000, and thinking that you might be able to pay less at the dealership that's selling it for $60,000. Now, this isn't a problem in Lexington or Louisville, believe me. You know, these are mature areas that have a lot of competition, excellent healthcare facilities. But this is a problem in rural Kentucky that have really poor areas of people that have difficult times in transportation. And this is, you know, something that I would like to see addressed, and what I call outliers, because the car dealership that's charging $60,000 is an outlier. Now, I did ask Tom Buford if I could use this, and this was a year ago, and he said yes, and so I just keep using it. It's on our website. He sent me an email. It said, CON is for protection of Medicaid, so access is limited, and it most likely causes those with CON to charge more in underserved areas. They have a monopoly on provided services. And this, of course, is an opinion. We have no data for that. But a lot of CON, and especially when you look at nursing homes, nursing facilities, the reason for the CON is to keep 1,000 nursing home facilities from being built and bankrupting the state. And again, that's an opinion. That's certainly not what the statute states it is, and certainly not what anybody in government will state it is, because they can't violate the law of the statute. But let's, be realistic. That's the last thing to be dropped from any CON law in the nation is long-term care facilities. And my opinion is because it's a cost breaker for estates that are already financially strapped. This is an old slide. John, are you here? John Martin?
No, I think he had to leave.
Oh, he had to leave. Oh, that's right. He had a doctor's appointment. He's the expert on the Jessamine County drive for the hospital. And I don't know if that's reached a conclusion or not, but they've been trying to get a hospital in Jessamine County, which is south of Lexington, one of the fastest growing areas in the Commonwealth. They certainly need to have a hospital. The citizens there have to only access is up through a very busy road, which sometimes gets clogged with traffic, and they're quite anxious to get a hospital and get one approved. And how well has CON worked in the United States? Well, the case against the CON is at the time, of course, the CON was adopted. Publicly held for-profit hospitals were not commonplace. CON was enacted with the assumption is that you have a community nonprofit hospital that comes into the area. The healthcare industry has changed. Marissi has made the statement that the principal difference between for-profit and nonprofit organizations is how profits spend. For-profit enterprises spend them on shareholders. Nonprofit enterprises are prevented by law from explicitly doing so. And granted, there are a lot of nonprofits, or I shouldn't say a lot, there are some nonprofits, or a few, that act like a shell for-profits of the nonprofit entity, but they contract everything else out to their for-profit little partners. I mean, I've seen it where they've got central supply, lab, everything in a separate for-profit corporation. So hospitals can be very complex when you look and say, well, what type of organization are you? But again, in Lexington, I think when you look at UK St. Joe's and Central Baptist, we've got three of the finest organizations that are highly competitive. So, someone asked me if is there competition between hospitals in Lexington, and I said, oh yeah, there's a lot. I mean, I think it was an NPR reporter wondering if they should allow mergers if Lexington had competition. I said, oh yeah. Any rate, economic studies. And this is what's interesting. CON tends to increase costs. 6 studies found that. Now notice it says tends to do that. If they find a cost increase, it's not a whole lot. A whole bunch of studies have found little or no effect on costs. So that kind of, when you look at it, that means that it's not doing much, but it hasn't shown a huge amount of where it's, costs have gone out the window. So it's of harm to really motivate people to say, hey, we've got to get rid of the CON. Now, the Federal Trade Commission, and they have all of this on the website, and if you ever want to know anything about CON, go here. In 2004, they had 27 days of testimony from 250 research and panelists. And believe me, anybody in Kentucky, any single person doesn't have 1/100th of the knowledge that is on that website about CON. The Federal Trade Commission's conclusion was that on balance, CON programs are not successful in containing healthcare costs, and that they pose serious anti-competitive risks that usually outweighed their purported economic benefits. And now let's talk about healthcare systems. One is we can talk about systems that regulation is into a large extent lacking. Mr. Ken Connor talked about this a little bit this morning, and that we do not have, for example, a public service commission that you see in utility systems. There is little regulation regarding hospital state quality. We talked about in the beginning of the program, I presented some joint commission data that certainly may be changing, where they're becoming more under Department of Health and Human Services. There is no public service system, and without competition, it is possible in a for-profit situation to have a scenario of high prices and low quality. And this can lead to net revenues in poor counties of up to tens of millions of dollars coming out of the county per year. Utility industry, when they tried to just modify their public service commission oversight just a little bit, the Herald Leader just absolutely attacked that and wrote very poignant editorials. The healthcare industry, so far, there's been no oversight. Now, the second type of system, if you're not going to have regulation, can of course be through competition. And if you have neither, then you kind of have anarchy. And competition has to do with consumer-driven healthcare. And that was the presentation that Dr. Nancy Wilson gave of the effort from the Department of Health and Human Services, that they're trying to promote transparency so that consumers can make choices. Nope, wrong direction. Now, if you look at the airline industry, 1978, they were deregulated. They have a Boeing 747s. Those things cost $200 million. When you're looking at one of them, you're looking at a hospital. I actually looked up to see how much one of those things cost. They do not have any guarantee of having any seat filled when they land the plane. Now, that may be good or bad, because I'll tell you, when I flew back from Brussels to Atlanta, mine wasn't filled. In fact, it only had about, it was only a quarter, I bet it was only a quarter, well, not even quarter filled, I bet it was 10% filled. And we arrived an hour early. That's how empty it was. I mean, they were, that's how empty it was. We arrived an hour early. They could burn extra fuel. They weren't carrying any weight. It kind of made me feel safe. I felt a terrorist wouldn't hijack it or shoot it down. There wasn't anything in it, There was just Dr. Kavanagh, and he was pretty sick. So at any rate, but at any rate, you could at least imagine the disparity here of airline executives who are pulling out their hair, paying health care costs, and wondering why they too can't be protected by government sanction or by government monopolies. Where competition works in healthcare, I think it's pretty much assumed that it does work in plastic surgery. It's also worked in LASIK surgery. These are areas that are not covered by insurance. Started with a few providers, cost us several $1,000s, and it slowly has gotten down in price as competition has expanded. Now, concerns about eliminating the CON. One is that nothing that I have said that CON causes a disaster in healthcare. I mean, the Federal Trade Commission has their opinion, et cetera, but there really hasn't been economic research studies that say that if you have a CON, it's going to create a huge disaster and bankrupt your state. The second thing is, and I think is most appropriate, is fairness. And in America, we like to be fair. As many individuals and industries have purchased CONs at huge prices from other individuals and industries that obtained them. Would it be fair to them to, in a single day, make their investment go broke? Well, that actually happened to me about a couple weeks ago. But at any rate, the way the economy is going. But that is a problem. And finally, there's a concern over the protection of small rural hospitals. What will happen to the small community hospital if you have big industry or Walmarts of healthcare moving in, undercutting them in prices, within the short term, once they're out of business, in the long term, ratchet down and come on the community. So, and those are major concerns. Now, what is feared? One is surges. That's initially when states eliminate a CON. All of a sudden, everybody builds at once. You got 20 groups want to build a surgery center in Jessamine County, eliminate CON, 20 surgery centers that year start to be built. And that's called a surge. And those have been experienced in a few states. One is Arizona, who saw them in open heart surgery programs, and nursing home beds were doubled in 5 years. Tennessee, home health care agencies, and that caused Tennessee to reverse and go back to having a CON. Wisconsin, hospitals and psychiatric hospitals had surges. Texas, nursing home psychiatric hospitals had surges. Ohio had surges all over the place. Ohio, ambulatory surgery centers and pediatric services and dialysis. But over time, that tends to go away. There were also 2 other states, I think in the 80s, that withdrew and then reenacted the CON. But that was a long, long time ago. And of course, healthcare has changed since that time. 1998, and this was the last economic study on CON, was on Conover and Sloan, and they found that mature CON programs resulted in a 2% reduction in bed supply, but higher cost per day and per admission, and with higher hospital profits. And that study is the study that's the most, well, it's the last study that was done, and it's the one, and probably the only one, that has found a significant problem with increase in costs in CON, that the longer the programs become more mature, the more problems you have with increase in cost. Now, regulatory changes. One is the statute gives the governor's office very broad authority on the CON, and there is no preconditions on its use or on how it can be determined that CONs be granted. They do want the iron triangle to be expanded on all 3 legs. Now, if the CON were weakened by regulatory changes, the licensure process certainly could be used to assure quality. So I don't think you can just go in and make changes to a CON that are really significant with also looking at licensure to pick up maybe some of the changes to make sure that you're assuring quality. And licensure can do that. Now then, I think that there are 2 really big problem areas. One is, my opinion is that hospitals that have an effective monopoly need to be scrutinized. Especially hospitals that are for-profit, because I feel that for-profit means that you are in the marketplace. You are should be with competition. In fact, there's some SEC reports that state that for-profit hospital corporations have right in the report that they target low competitive environments. The CON was, again, the concepts developed before this type of facility was commonplace. And so one of the things that I think could be considered is that if you have for-profit facilities that have an effective monopoly within a county and they reach a certain age or they reach a certain size, that a nonprofit CON would be available to come in and compete. That would be one pie-in-the-sky suggestion that I would like to make. The other is interesting, and this is one I'd really like to throw out. First of all, Kentucky has no CON board anymore. That went out with the Health Policy Board, and it's essentially at the option of the governor. CON boards across the United States have had, histories of corruption. They make, who knows how they're going to make decisions. How in the world can you decide whether UK or Central Baptist or St. Joe's should be the one building a hospital when they're all excellent quality hospitals? And of course you hear about how we can't describe quality to patients to compare. Well, how in the world are you going to do it to the CON board? I mean, they have no idea, can't describe costs. Well, how are you going to do it to the CON board? And these CONs, they're valuable commodities. Once a hospital gets one for free, they can turn around and sell it for multi-million dollars. I personally think that the state ought to just put them up for bid. You ought to set criteria for these institutions, and if they meet your criteria that you've set up, in other words, you've got quality criteria, all comers can bid for it in a closed bid process. Those monies are then put into a fund matched with federal dollars to go back into a pool for all hospitals in the state to provide indigent care. You would raise a ton of money with this. You could bet that you'd have tons of people bidding for that CON in Bullitt County or Jessamine County or wherever. It would be, something, and then when they sell it, they're selling something they bought instead of being given to. If it's a nonprofit and the state gives you a CON, that's one thing, but to give a CON to a for-profit institution, that has different connotations. Personally, I don't think there's any way that you can reliably tell who should build. I think certainly you can set up criteria of when something should be built, but there's a lot of areas in Kentucky that need to have facilities. The Department of Health and Human Services, I think, ought to identify, around Ashland, I don't believe they have an independent surgery center up there. They should identify CONs which need to be made available and put them up for closed bid. Take that money and get it matched with federal funds and provide indigent care, and I think you'd raise tons of money. Who knows what the bid would come in at, but it would be in the millions or probably tens of millions of dollars in order to secure it. Conclusion, I don't think Kentucky should be giving away CONs. I know, hospital CON I've heard is worth $5 to $10 million when it's sold. And that's just in a run-of-the-mill small rural area. I think in some of these larger metropolitan areas it'd be worth much more than that, and that we should use that to try to bolster our state budget. Okay, and that's my presentation. Does anybody have any questions? I try to present kind of a balanced view of the CON in Kentucky.